Good evening, everyone. First of all, let me thank Dr. Thomas Cherian and KSOS for giving me this opportunity. I'll be talking on management of OT protocols. As you know, endophthalmitis is the most dreaded and devastating complication of intraocular surgeries, which can lead to a permanent severe visual loss, and it can be prevented only by a strict asepsis. So, how that can be maintained in our OT? So, the airborne infections in OT can be prevented by dividing the OT into 4 zones. That's a protective zone, which includes the reception area, the waiting area, the changing rooms, etc. From where we enter the clean zone. That is the pre-operative room or the block room in our case, the recovery room, the doctors and nurses work areas, etc. And then we go into the sterile zone, that is the operating theatre, and then there is a disposal area. Multiple barriers should be provided from the protective zone to the aseptic zone to minimize the contaminants from exterior reaching the OR. And you can keep the doors in a zigzag manner, which will hinder the direct flow of air from outside. The OT should have its own ventilation, which has certain purposes. There should be filtration of air and purification, and also a positive pressure ventilation should be maintained, and there should be laminar flow and a proper air conditioning with controlled temperature, humidity and ventilation. So these are the NABH guidelines for a general OT, under which the Ophthal OT also comes. There should be a minimum of 20 air changes with a minimum of 4 fresh air changes, and a positive pressure of minimum 2.5 pascals is maintained to prevent the entry of outside air into the OT. Then air filtration has to be done, and humidity and temperature has to be maintained in the recommended levels. The AHU or the air handling unit must be an air purification unit and an air filtration unit. There should be air is filtered, and finally first by 2 pre-filters and then by the HEPA filter, which has an efficiency of 99.97%, and the air supply at the grill level should have a class 1000 per ISO quality. That is 1000, class 1000 means a cubic foot of air must have no more than 1000 particles of 0.5 microns or larger. And the laminar airflow ensures that the HEPA filtered cool air descends in a unidirectional pattern along parallel lines, and it will prevent the contaminated air from surroundings to from entering the central operating area, and this is limited to the center of the operating room, and the flow of air here is imperceptible, and this should be maintained by strict validation, and it should be done every 6 months as per ISO standards. We should check the temperature, humidity, the air particulate count, air change rate circulation, air velocity, the positive pressure, that is the pressure differential, and the validation of HEPA. HEPA filters should be done. So every 6 months you have to do this, and a validation certificate also you have to maintain, and that should be kept recordically. You should maintain a register, and preventive maintenance can be done every month, and there should be strict rules in an OR which should be followed by all those who are entering the OT. The operating theatre complex should be always kept clean. You should not allow dust or dirt to accumulate there, and it should never be dry dusted. Always wet mopping should be done, and the wet mops should always be cleaned, disinfected and dried. This is the daily protocol, and the aseptic techniques refers to the practices performed immediately before and during a clinical procedure to reduce the postoperative infection. So always remember that skin of staff and patient is an important source of contamination. So from the patient, it is prevented by the surgical drapes with adhesive edges, and in the case of staff, by the wearing of surgical gowns. So these barriers will prevent the entry of bacteria from the skin into the surgical wound. And there may be skin particles may be shed from under the gown, which are prevented from reaching the operating zone by the laminar flow. And always there should be a preoperative checklist according to which you have to check everything when you are preparing a patient, confirm the identity and the operative site. Always you can permit hearing aids, and for cataract surgeries you can permit even dentures. if the patient is being done under local or topical. And informed consent for the surgery as well as anesthesia should be obtained, and the timeout form should be read out before each case. Before and during the surgery, scrubbing of hands, gowning, gloving, draping, everything should be done properly. And always remember that items below the level of the drape are outside the field and they are not sterile. And trolleys should be placed within the confines of the laminar airflow to maintain a sterile field, and any sterile barrier that has been penetrated, either wet, cut or torn, is considered contaminated. Limit the number of people who enter the OR and close the doors during all procedures. And after each case, you should segregate the biomedical waste into color-coded containers, and instruments are returned to the TSSU for cleaning. And all horizontal surfaces which has been contaminated by the procedure has to be cleaned and disinfected. And trolley is set for the next case. So the biomedical waste management, so it should be passed through a corridor, disposal corridor, and first it should be collected in the color-coded containers and then pass through the disposal corridor. And all the registers should be maintained, should be filled, and all the implant labels should be pasted in the registers. And while using the disinfectants, always remember that you should check the expiry date, you should use the proper dilution, and always use a clean, dry container, then and always give adequate time for it to act. And never store instruments in a disinfectant, and never top up yesterday's solution. Always prepare fresh and use it for the day. Documentation registers have to be filled every day, and it has to be maintained. Cleaning of surgical instruments. After a case, the instruments must be rinsed with cold water immediately to prevent drying of blood and other body fluids, and then sent to the CSST for further cleaning. And manual cleaning is generally performed for delicate instruments with a soft brush. Always remember, should not be rinsed under running water, and you should not use saline, you should not use hot water. And the cleaning agents like detergents and enzymatic cleaners can help you in further cleaning, because water alone cannot clean the substances like oils, fats and proteins. And ultrasonic cleaners will help you to remove even the tiniest speck of dirt from unreachable areas like hinges, serrations, etc. And always after thorough cleaning, it should be inspected for cleanliness as well as functionality. And after cleaning, all the instruments are sorted, checked and assembled for sterilization. And always they are put in the perforated steel trays with a liner which will prevent damage of tips, and you should pack them well so that wet packing is prevented. Linen packing materials, that is linen can be used for steam sterilization, or you can use plastic for ETO and gas plasma. Paper plastic also can be used for steam and ETO. And always use chemical indicators to assure sterilization. And there should be a record kept for sterilization. And each pack should be strictly labeled with all the details so that they can be recalled in case of a problem. And these are the chemical and biological indicators which are used. And always the pouches are to be kept vertically to optimize the air level, air removal, the sterile penetration and drying or aeration. And recall is done in case of a problem. So the whole batch can be recalled from the label. And at the end of the day, wet mopping of OT walls and floor is done. Cleaning of all surfaces has to be done. And after switching off the AC, put the UV on and close the OT. And next day, you have to switch off the UV first, then put the AC on, and after 30 minutes, you can enter the OT. And air surveillance has to be done to detect the bacterial count in the OT air. We use the settle plate method, where multiple plates are kept in different areas of the OT and results are interpreted as a whole. And at the time of exposure is 30 minutes. 10 to 12 colonies formation unit can be taken as the limit in ophthalmology OT. And always swabbing also should be done. Swabs moistened with nutrient broth or saline, it's used, or distilled water is used to take samples from the surfaces or equipments. And the areas to be swabbed are mentioned here. Swabbing of the air conditioned filters may be done. It's not done regularly. And every week and every month, you have to do a thorough cleaning of the entire OT and equipments, followed by fumigation and culture. Monthly, you have to take out all the equipments and you have to clean the OT thoroughly. And so the take-home message is, let's keep our infection free, Strict adherence to the OR protocol is the key to prevention of endophthalmitis. So you have to proper maintenance of registers and correct labeling of the pack trays, and biomedical waste management in the recommended manner has to be done for this. Thank you.
Dr. Girija, that was wonderful. I think what we will do is we'll have a panel discussion. So you can stay back till the end. We can have a panel discussion.
Sure.
And I'll request Dr. Shashikumar. He has written a book. We look forward to hearing you, sir. He'll be talking on surveillance at the gate, what goes in. So while Dr. Shashikumar is putting up, just for one small note, which there are definite protocols, systems in place when a flight takes off. And similarly, in our system for an OT, we have to maintain the protocols very strictly, because if we start making mistakes, which sometimes we do, and similar mistakes the flight people make, they have a lot of crashes. What is encouraging, we were discussing just before the meeting, is that there are much lesser incidents of endophthalmitis happening now, which means most people are following those protocols in a very rigorous manner. So it is not difficult, we can do that. Thank you. Dr. Shishkum.
Thank you, Dr. Thomas and Dr. Ajay Arora. Now that we have heard what the OT protocols are, we'll go for the fluid, the instruments, what all things can lead to endophthalmitis if we are not careful. The incidence of postoperative endophthalmitis ranges from 0.02 to 0.26 worldwide, and in India it is reported to be 0.04 to 0.15%. And the source of infection in cluster endophthalmitis is typically exogenous and multifactorial. Even with the proper use of preoperative povidone and sterile precautions, the bacterial contamination of the fluid that comes out of the operating field is 31%. That is reported. But not all these cases will end up in endophthalmitis. The sources of infection from the consumables, usually it is from the intraocular solutions. It can be the irrigating fluid, the viscoelastic devices and drugs, and even the trypan blue dye. Contaminated operating room environment, mainly the ACs and the inlet, the air that is taken to the AHU. If there is a construction going on there, if there are a lot of dust rising out of the outside the AHU, all these can lead to a contaminated OT environment. The phacoemulsification machine, previously we had the inner tubings that was supposed to lead to endophthalmitis, but inadequate cleaning and inadequate processing of the phaco tubings and the phaco probe can also lead to endophthalmitis. Contaminated instruments which are inadequately processed. As Dr. Girija mentioned, the instruments should be cleaned. When it should be cleaned? It should be cleaned immediately after surgery. We'll come to that later. Even local anesthetic drops has been reported to produce endophthalmitis, and IOLs preserved in solution, that also was a cause of endophthalmitis as reported in literature. In all these cases of endophthalmitis, we were not able to identify the organisms, but however, in cluster endophthalmitis, the commonest organism that is reported is Pseudomonas aeruginosa and related species. Burkholderia, Enterobacter klebsiella has also been reported in cluster endophthalmitis. Staph epidermidis adhesion and biofilm formation on 4 types of IOLs have been studied: silicon, PMMA, hydrophilic and hydrophobic, and it has been reported that the biofilm growth occurred on all types, but the least in hydrophilic acrylic. Cleaning, when we should clean the instruments after the surgery. Usually in most of the OTs, what we have seen is that suppose if there are about 10 cases, all the instruments after the surgery is kept there and all the instruments are cleaned at the end of the surgical session. That is not proper, because it has to be cleaned immediately after surgery. Why? To avoid the biofilm formation. Biofilm formation has got different stages. In the earliest stages, that is within minutes, if you can clean the instrument, you can get rid of the organisms. Otherwise, it will get adherent, it will accumulate all the extracellular polymer substrates, and all this becomes very hard, and it gets lodged in the instruments. And if it is a cannulated instrument, it is very difficult to dislodge it from that instrument. Cleaning of instruments is important, and then all instruments should be dried before processing. All cannulae and all hinged instruments has to be cleaned in an ultrasonic cleaner, but care should be taken not to mix different types of instruments. Chromium plated instruments should not be mixed with titanium instruments, because then there can be electrolytic deposition of electrolytes. And the cannulae should be flushed with distilled water. If you have got an air gun, that is good enough, and it should be later flushed with air, so that it is made completely dry. And always autoclave the heat resistant instruments. There is no role for chemical sterilization in ophthalmology. And do not reuse an instrument without sterilization. There are certain hospitals where cannulas, the bimanual cannula, are reused for surgeries, but I mean that is not a good trend. Consumables, that picture is shown, it is a real picture which happened in our hospital. You are lucky if you get a bottle like this. It is quite obvious. And the quality of OVDs, irrigating fluids, Trypan Blue, all these are very important, and you should buy it from GMP certified, good manufacturing practices, certified companies. And all irrigating fluids or the Trypan Blue, whatever the consumables that you use, one sample from that batch should be cultured, and you should keep it documented. And then if the culture is negative, then you can use the consumables from that particular batch. This also I have got it from our hospital. This is a Trypan Blue bottle, and the endophthalmitis from this has been reported. We didn't use it. Luckily, we saw that deposits there. It happened in the disposable cannula also, and it grew aspergillus. Irrigating fluid, the best one is the collapsible bottle. And if you are using a plastic bottle like this, most people put an airway there, but airway should not be kept at the bottom, it should be kept at the top, above the fluid level. Then the best technique to detect colloids in the fluid, in the irrigating fluids, is to test by the Tyndall phenomenon. Physical inspection for Tyndall effect and broken seals and discoloration, it should be done. And as I said before, culture should be taken from each batch of these intraocular solutions. Instruments, if there is a outbreak of endophthalmitis, you will have to culture even the cannulae. And the fluid that has been washed out of the cannulae, you can culture. Even if there is a Simcoe cannula, you can even cut the Simcoe cannula there in the blood agar plate, and you can culture it. The effluents from the tubings, and as I said before, you should recycle, autoclave all the instruments before recycling. And there were reports previously that some of the sharp instruments can be sterilized in acetone or even Sidex, but that should never be done in an ophthalmic setup. Phaco tubings, it's very important. When you are using the recyclable tubings, you should do this helix test. Helix test is it's a tube having 1.5 meter length, and there at the end there is a container where you can keep the indicator, and then do one cycle with this device. And that indicator, if it doesn't, I mean, if it shows a the process is proper, then you can assume that the vacuum cycle of your autoclave machine is proper. Finally, this is an ethical question. If you get a case of endophthalmitis from a consumable, should you report it? I think you should report it to your peer groups, warn them, want them with the batch number. That I had even not even endophthalmitis. If you have a TAS or even a suspicious reaction, you should report it among your peer groups. But then care should be taken that you should supplement with evidences. You should culture that, and if you get a positive culture, well and good. Otherwise, this company can sue you for maligning their reputation. So be wary of all these things and maintain a proper log of all OT procedures, like the autoclave procedure. Need not get a printout. You can, even the ordinary autoclave, you can use a log. When have you started it, what is the temperature, and what is the holding time. All those things can be maintained, recorded in a book, which will be of very use. All the sterilization indicators has to be kept properly and documented properly, and the batch number and the details of all the consumables should be recorded properly and kept in your OT register. Thank you. Thank you for patient hearing.
Thank you, Dr. Shashi. That was exhaustive, and we had a thorough knowledge of what goes in. Now, with all the best practices in the OT, all the protocols in place, and everything that goes in have been taken care of, still on the first post-operative day, we find that the patient has a corneal edema. The vision is not very good. Patient has some pain. The first response from the surgeon is, no, it can't be. It was an uncomplicated case. I took just 10 minutes for that, and it can't be. So how do we differentiate between a TAS and an endophthalmitis? I request Dr. Sindhu to enlighten us. Sindhu is consultant vitreoretinal surgeon at Little Flower Hospital, Angamali.
Good evening all. First of all, I would like to thank KSOS and Thomas Cherian sir for giving me an opportunity to speak in KSOS. So today in this next 10 minutes, I'll be discussing about toxic anterior segment syndrome, how you differentiate it from endophthalmitis, and in very short about the management. So this is the normal day one post-op of an anterior segment surgeon. Patient is happy, surgeon is happy. But once in a while, this is the scenario. So now the question is whether it is an inflammation or whether it is an infection. So let's refer to VR colleague. What next? So let me come to two case scenarios first. A 55-year-old female, a diabetic, with an uneventful cataract surgery on day one post-op, comes with a visual acuity of counting finger close to face, but the fundus details are hazily seen. As in the picture, you can see conjunctival congestion, circumcorneal congestion, 1 millimeter hypopyon, fibrin sitting over the IOL. The patient was immediately started on frequent topical steroids along with the topical antibiotics and cycloplegics, reassessed the same day evening, and the next picture shows day 3 post-op with a clear cornea, the solved hypopyon, and good view of fundus with a visual acuity of 6/9. This was a case of toxic anterior segment syndrome. Coming to the next scenario, a 66-year-old female with an uneventful cataract surgery. Day 1 post-op, everything was normal, but day 3 comes with a visual acuity of perception of light. You can see the conjunctival and circumcorneal congestion, corneal edema, 3 mm hypopyon, and there is no view of fundus. Then we got a B scan done to see a clump of vitreous echoes with the choroidal thickening. As the visual acuity was perception of light, the patient underwent pars plana vitrectomy with intraocular antibiotics along with oral antibiotics and systemic steroids. And next post-op day, the patient received topical steroids, topical antibiotics and cycloplegics. Now this is the photo showing the post-op day 14 with a visual acuity of 6/12, and this was a case of acute post-operative endophthalmitis. So now what is TAS? It is an acute sterile post-operative inflammation following anterior segment surgery. Remember, if there is a traumatic surgery or if the patient has got a traumatic cataract or a patient you are operating with a pre-existing uveitis or a fuchs or pseudo-exfoliation, or in a situation where you use CTR, iris hooks, you can get normal than excess inflammation. That doesn't come to TAS. So this was known in 1980s as sterile endophthalmitis, and it was renamed by Mons et al. As TAS in 1992. So when an outbreak of TAS comes, every time it's difficult to find out the source. As discussed earlier, the most common causes is the improper cleaning of the instruments. Other is anything which goes into the eye, whether it is your BSS, whether it is your trypan blue, whether the viscoelastic or with your intraocular lens, anything can cause the stars. So what happens is when the toxin enters the eye, there is severe inflammatory response with anterior segment damage. If not treated properly, can lead to corneal decompensation, intractable glaucoma and cystoid macular edema. So when a TARS outbreak occurs in an institute, the surgical faculty halts the procedures and thorough investigation is taken. It is discussed among the colleagues and other colleagues in the region, and you have to find out the source. And the staff theatre OT protocols has to be reviewed and if necessary has to be changed. Now endophthalmitis is purulent inflammation of the intraocular fluids caused by infection. So time of onset, day 1 post-op, more likely to be TARS. Usually it occurs within 12 to 24 hours post-surgery. However, there are reports of late onset TARS after tapering the topical steroids. Endophthalmitis usually seen 4 to 7 days post-surgery. However, there are reports of endophthalmitis seen even on day 1. So based on the symptomatology, pain is more in favor of endophthalmitis. However, you can get pain in TARS if there is high intraocular pressure. Both the conditions can cause defective vision. Lid edema, conjunctival congestion, purulent discharge more in favor of endophthalmitis. Always never forget to look the surgical incision site, especially the upper lid has to be retracted and seen to see whether there is any corneal infiltrate, and the sections has to be inspected for wound leak or iris prolapse. Remember, once the cornea is involved, the game in endophthalmitis is gone and the prognosis is poor. Corneal edema can occur in endophthalmitis. The limbus to limbus corneal edema is classic of TARS. Iris, you can get a fixed dilated pupil, sectoral or diffuse iris atrophy. Endophthalmitis, many a time we see that pupil is myotic and resistant to dilatation. Fibrin and hypopyon can occur to varying levels in both the scenario. Fundus, remember in toxic anterior segment syndrome, there is no involvement of the posterior segment, there is no vitritis, so if you don't have a fundus view, go for a B scan, the B scan will be normal in TARS. Whereas in endoph, sometimes you can see the exudates. When you don't have any glow or yellow reflex, go for a B scan. You can also encounter presence of retinal hemorrhage, periphlebitis and occlusions in endoph. The intraocular pressure can be normal in TARS or it can be high if there is trabecular damage. In endophthalmitis, it can be normal, low if there is choroidal and retinal detachment associated with it. It can be high also in inflammatory condition. Culture is always sterile in TARS. It can be positive in 60 to 65% case of endophthalmitis. So if there is a suspicion whether it is TARS or endophthalmitis, day 1 post-op, immediately put the patient on topical Predfort hourly and give along with it topical antibiotics, and if the IOP is high, start anti-glaucoma medications also. Before you leave the OPD, reassess the patient same day evening. Look if there is any signs of improvement. If there is signs of improvement, continue same treatment and see the patient next day. However, in your reassessment, if there is no improvement, go for a B scan, and to be on the safer side, consider it as endoph and do tap and injection. If it is an acute postoperative endophthalmitis, as per the EVS guidelines, if the initial visual acuity is PL+, go with the pars plana vitrectomy. If the initial visual acuity is hand movements or better, first tap and inject is performed, and after 48 hours the patient is reassessed. If there is no improvement, go ahead with pars plana vitrectomy. Now, after the ESCRS guidelines have come, especially with the availability of wide-angle viewing systems with smaller gauge instruments and 36 mm cannula and lot of vitrectomy facilities have evolved, the ESCRS guidelines have suggested immediate and complete pars plana vitrectomy with intraocular antibiotic as the gold standard, because it is according to the Latin synonym UB pus AB evacua. Wherever there is a pus, it has to be evacuated. And the tap plus intravitreal injection is being considered as a gold standard. So the take-home message is differentiating between endophthalmitis and TARS is purely a clinical diagnosis, and you can take the help of a B scan for the same. Both the conditions have to be identified promptly. Both of them the treatment has to be started immediately for a successful outcome. Thank you.
Thank you, Dr. Sindhu. I think just stay back. We'll have panel discussion at the end of the meeting. Wonderful presentation. It's very important. I'll now request Dr. Dinesh Talwar, DT as we call him. He will be giving the keynote address. Dr. Dinesh doesn't need any introduction. He's a national figure, a prominent vitreoretina surgeon. And the best part about him is that he is always inquisitive. The same thing which we are talking, in a way, he will look at it in a different manner with a lot of inquisitiveness. So it's very challenging to actually, fight out with him on discussion. I always try to do that, and inevitably I fail. Dr. Dinesh Talwar, relooking the EVS and management of post-operative endophthalmitis. No, I said it's a compliment because...
I'll take it as a compliment. Because it's important for all of us to keep our minds working. We have to keep our minds open. We have to be ready to question everything that is said. Only then will something new come out, and only then will something better come out. You know, the EVS came out 3 decades back, 1995. And still everyone keeps saying EVS says this and EVS says that. I'm not even sure whether now even the abstract of that EVS has been read by somebody who's quoting the EVS. The important thing is, what did the EVS find? Now, before we go further, this is my disclaimer and financial disclosure, though it's not relevant to this particular talk. So what did the EVS show? It said intravitreal antibiotics are effective for postoperative endophthalmitis. Yes. It also said that in cases who have PL positive vision, immediate vitrectomy is better for management. And finally, it said systemic antibiotics have no advantage when you're giving intravitreal antibiotics. It didn't say systemic antibiotics are of no use. What it said was, if you're already giving an intravitreal antibiotic, then systemic antibiotics don't give you an added advantage. We'll question that also. So what were the unanswered questions after that? The question is now, is it that the endophthalmitis patients we see now are more severe? Now the reason I'm making this statement is, only 4% of the culture positive patients who were there in the EVS were gram negative. Whereas now, almost 20% of our patients are gram negative and 10% are fungal, both categories which don't respond well to treatment. So the question becomes, should vitrectomy be the initial treatment? But then there's another question. What about the newer intravenous antibiotics that have come now? The antibiotics used in the EVS were amikacin and ceftazidime as a routine, and both have a poor intraocular penetration. It's like actually giving a drug that doesn't work and saying it didn't work. But what did the EVS not really answer? The fact is, they gave intravitreal antibiotics to both the groups. The TAP group was the one which got antibiotic. The other group got the intravitreal antibiotic along with the vitrectomy. So that presupposes that intravitreal antibiotics are completely safe. But don't they have a toxicity? Isn't it possible that there is a toxicity of the intravitreal antibiotics? And that was something that nobody bothered to check out. What about patients with media too clear for vitrectomy? How do you manage them? Maybe the group will tell us during the further discussions. What about management of post-traumatic endophthalmitis or endophthalmitis following a vitrectomy? And finally, what about endophthalmitis cases with RD? So we did a number of studies after the EVS from the period from 1996 onwards. And we wanted to first see whether there's a toxicity of intravitreal antibiotics. So we did vitrectomy with TAP, and then we did the vitrectomy without TAP. So we found there wasn't any significance. But then an alternative view comes in. Okay, it's not toxic, but the point is it needed? if you've done a vitrectomy, do you need to give an intravitreal antibiotic? Well, actually, it's not. So this is the other important thing. And incidentally, we do know that if you've given a vitrectomy, if done a vitrectomy, the toxicity does have a risk of increasing. In fact, Payman used to advocate decreasing the dose of intravitreal antibiotic. What about immediate vitrectomy versus late vitrectomy, delayed vitrectomy? That means the patient can't get the vitrectomy immediately. Is it okay if he gets an intravitreal and then goes for vitrectomy? Well, both are equally good. What we saw was, the conclusion we reached was that, okay, you don't have a facility for vitrectomy, go ahead and do the TAP, give the intravitreal antibiotics, but send immediately to the vitreous surgeon, who can within the next 24 to 48 hours take up the patient for vitrectomy without causing an adverse effect on the outcomes. And finally, we decided to do studies on post-traumatic endophthalmitis, and we wanted to assess the role of a radical vitrectomy, what you call a complete vitrectomy today. And we found promising results which have been now substantiated by the SEEVE study, which is complete and early vitrectomy for endophthalmitis. But how do, with all these studies now, how do we manage today, keeping EVS in the background, in mind? Well, the mainstay of management still remains vancomycin 1 milligram and ceftazidime 2.25 milligrams. But we do know that the resistance to ceftazidime is increasing. And this is supplemented with topical steroids and antibiotics, cycloplegics, systemic steroids, and intravenous antibiotics, or in case of ciprofloxacin, you can even give oral ciprofloxacin. It has the same penetration as intravenous ciprofloxacin. Incidentally, ciprofloxacin has a good penetration into the vitreous cavity, and the newer fluoroquinolones have even higher penetration. But the other group, there was one patient whom we were talking about day 1 endophthalmitis. Fortunately, that was day 1 TARS, but not day 1 endophthalmitis. But if you have any infection within the first 48 hours, you can consider that this is a fulminant endophthalmitis. And in this, I would definitely not consider ceftazidime as my second drug. With vancomycin, I would add amikacin. And if I believe that the infection is very severe, I would actually prefer a combination with tazobactam piperacillin or meropenem along with vancomycin. The adjunctive treatment remains the same. Now, you know, the amazing thing is that this information is embedded in the EVS study. If you look carefully, it says those patients who have an onset within 2 days of surgery, have an afferent pupillary defect or light perception vision only, are associated with gram-negative organisms. That means they already realized that, though they did not do anything to investigate that further. The conventional vitrectomy you would do if the vision is worse than hand movements. But what is hand movements? You know, in the EVS, the definition of hand movements was the inability to tell the correct orientation of hand movement, vertical or horizontal, at 60 centimeters, more than half a meter, and 4 out of 5 times. Frankly speaking, this translates into a vision of at least counting fingers at close to face, and most of us would end up giving an intravitreal at that stage when actually the patient, even by the EVS, requires a vitrectomy. Now, as far as the surgical management is concerned, conventional vitrectomy is fine, but there are certain situations where you need to definitely consider a radical complete vitrectomy, and this is those cases who have severe postoperative endophthalmitis. And how would you define that? If you see on ultrasound, the ultrasound is not diagnosing your endophthalmitis, but if on ultrasound the exudates are there till the retinal surface and there is no PVD, this case is going to need a complete vitrectomy. And if during vitrectomy you find that there is no PVD and the exudates are right up to the retinal surface, you need to go ahead and do a PVD, create a PVD and do a complete vitrectomy. Wherever you suspect fungal endophthalmitis, that's another indication for doing a complete vitrectomy. Now, what is a radical vitrectomy? It's a complete vitrectomy or as complete as possible. You create a posterior vitreous detachment if required. Incidentally, this is a misconception that the retina is very friable at that point. At the disc, the retina is the thickest and is least prone to tear. Tears which occur during this surgery will occur at the equator, and nobody advises you trying to do a PVD induction at the base, which is something not possible. So you only have to trim the vitreous at the base, but you don't have to go. You don't have to try to induce a PVD at that level. You remove any cyclitic membrane if you can see it, and once in a while you may need to do an IOL removal too. In this new paradigm, you inject silicone oil for long-term tamponade at the end of the vitrectomy. And now what role does it play? First, it occupies the entire vitreous cavity. That's 80% of the space in the eye. And silicone oil is not penetrable to any organism. Silicone oil doesn't have any antibacterial properties, but it is not penetrable to any organism. High antibiotic concentrations are achieved in the fluid in the retrosilicone space after systemic administration. Here comes the role of newer antibiotics, which anyway have better penetration, and in the presence of silicone oil, they are adequate to eradicate many, many organisms. And the topical antibiotics in this situation will be adequate to take care of the anterior segment infection. At the same time, this is also clear, so it's optically clear. You need to, there's some break, you can laser, rapid visual rehabilitation is there, and it prevents hypotony too. We found results like this in patients, 12 patients we did in both the groups, one conventional, one radical vitrectomy. 7 out of 12 patients got a vision better than 660. Only 1 out of 12 managed to get that with a conventional vitrectomy, and this was, even in this very small group, statistically significant. So if you have patients with severe endophthalmitis, you have an effective alternative approach which can improve your visual outcomes. This has been substantiated by the SEEF study, which did not give the figures of how often they put in silicone oil, but they say if needed, don't hesitate to put it. And they found, as you can see, better than 20/40 vision in 91% of patients who had a complete vitrectomy compared to 54% in the EVS. So this is what is so important. You can get much, much better results. So the take-home message, ladies and gentlemen, here are intravitreal antibiotics to be followed by intensive topical and systemic antibiotics and steroids as soon as there's a reasonable possibility of endophthalmitis. Refer for vitrectomy all patients who show inadequate response to the intravitreal injection within the next 24 hours. A core vitrectomy for moderate severity of endophthalmitis, radical vitrectomy for severe endophthalmitis, and early intervention is the key to successful management. For general ophthalmologists, the main message is intravitreal antibiotics are still there to stay. Intravenous antibiotics have an adjunctive role only. In PL positive eyes and even hand movements, if the facilities are good, go ahead and send the patient for an immediate vitrectomy. But if the facilities are not available, an intravitreal antibiotic should be given and let the patient be followed up, sent for referral immediately. For vitreoretinal surgeons, the message is, in today's world, vitrectomy is not more hazardous, results are equally good, and intravitreal antibiotic is not necessary at the end of a vitrectomy. And if you have the newer antibiotics, we still have to evaluate their role in a bigger study, but they definitely play a role in patients who have fulminant endophthalmitis. Thank you very much, ladies and gentlemen.
Thank you, sir. That was a master class. I'm sure you'll have more questions in our panel discussion. Now, for the last talk of the session, before we go into our elite panel discussion, I invite Dr. Rahul Menon to talk on endogenous endophthalmitis. How did it intrude? Dr. Rahul is consultant vitreoretinal surgeon at Chaitanya Eye Hospital, Ernakulam.
So, good evening, everyone. So, I'll be talking today about endogenous endophthalmitis. So, it occurs from hematogenous spread of organisms from a distant source of infection. accounts for about 2 to 8% of all endophthalmitis. Pediatric endogenous endophthalmitis is even rarer. So these are the various risk factors which include chronic diseases, patients on chronic immunosuppressive therapy, intravenous drug abuse, and so on. Now, unlike exogenous endophthalmitis, in endogenous endophthalmitis, the choroid and ciliary body are the first site of ocular infection because of the higher blood flow. And then the retina and vitreous have a secondary involvement. It is associated with a very high complication because studies have shown that around 14 to 43% of the patients end up requiring enucleation or evisceration. Now, it can be unilateral or bilateral. Many studies have said there is a right eye predominance because of a more proximal and direct blood flow from the internal carotid artery. It can also spread directly from the CNS via the optic nerve. Now, the microbial source of endogenous endophthalmitis significantly varies in different parts of the world. Fungal endophthalmitis is more common in North America, where IV drug abuse has been implicated as one of the cause, and Canada is the most common organism isolated. In Eastern Asia, it is the gram-negative bacteria, and Klebsiella pneumonia has been the most common associated organisms. Bacillus group has been associated with IV drug abusers. Now, as we've seen, geography plays a very important role in identifying the etiology for endogenous endophthalmitis. So we have this excellent 10-year study from Shankar Netralaya. So they studied 61 eyes of 58 patients, in which about 46% of the patients had no predisposing condition. Culture positive was found in 58%, and of which gram-positive organisms were 15.5 and gram-negative were 34.5. Pseudomonas aeruginosa was the most common isolate, and in the end, 12 eyes had to be eviscerated. Now, these patients tend to have a poor visual outcome because of the invasive nature and a non-specific presentation causing a delayed diagnosis. Also, Limetol has found that intravitreal antibiotic therapy or vitrectomy, both still, even if we get the best treatment, they tend to have a very poor visual outcome. But however, the rate of, what they found was the rate of evisceration was lower in patients who underwent vitrectomy. Now, in microbiological histopathology, the infective foci has been localized to the inner choroid, from which it extends to the Brooks membrane, retina, and eventually involves the vitreous. Isolated retinal lesions can also be identified in about 14% of the cases. Now, vitrectomy has, in microbial culture, vitrectomy has a higher diagnostic yield for culture compared to vitreous aspirate. Now, the possible reason could be during vitrectomy, we can take the sample closer to the retinal surface because like I said, unlike the exogenous endophthalmitis, in the endogenous, the infection is from inside out. PCR analysis has a very key role in the analysis. It has very high increased sensitivity. Like Soman group had found that in their cases, they could identify infection in about 100% of the cases compared to culture where they could only identify the organism in 37.5%. Also, the very great thing is the rapid diagnosis. It takes about 90 minutes to get a report. Now, the only limitation being we are unable to determine the antibiotic susceptibility with the PCR. Now, the management is simple: aqueous, and we have to take an aqueous or vitreous swab, send it for microbiological analysis. Systemic therapies definitely has a key role in endogenous endophthalmitis because it treats both the remote and ocular foci. And also, since the blood ocular barrier is broken, the drug can achieve a therapeutic concentration in the eye. Oral steroids is extremely controversial because most of these patients tend to be in a state of systemic sepsis. And also, unlike the post-operative endophthalmitis where toxins play a key role, here one of the pathogenesis is septic emboli. So steroids are usually not preferred. So the treatment includes we have two options: intravitreal injections or vitrectomy. Now, usually suspecting a bacterial infection, we treat with intravitreal vanco or ceftine imipenem. The intravitreal antifungals are talking about it in detail. So we have the polines like amphotericin B, in which studies have showed that about 20 to 100 micrograms have shown no toxicity, but the usual dose that we give is about 5 to 10 micrograms per 0.1 ml. Triazoles like voriconazole are broad-based antifungals. The concentration of less than 250 milligrams, 250 micrograms have been well tolerated, and the dose that we give is about 50 to 100 micrograms. Fluconazole has a response rate of more than 90%, and the dose that we give is about 100 microgram per 0.1 ml. Very few data is, there are few newer antifungals such as poscanazole, which has a very good activity against Fusarium, but it is available as an oral suspension, and very few data are available whether it can be used as an intravitreal agent. Flucytosine has a very good action against Candida, but it should not be used as a sole therapy. It should be used only as an adjunctive treatment. Now, the systemic antifungals, usually it requires a minimum duration of 6 weeks treatment. Depends upon the resolution of ocular lesion. Severe involvement usually requires a longer duration of treatment. Fluconazole has a good activity against Candida. Itraconazole can be used for Aspergillus and Fusarium. Amphotericin B given systemically has a very poor ocular penetration. Now, vitrectomy for endogenous endophthalmitis, I don't need to talk out much about EVS study, as Dinesh sir has already given a very detailed, elaborate explanation of the same, but it was not included in EVS study. Now, when I was researching for this endogenous endophthalmitis, many studies, like, articles, they kept mentioning, popping up that EVS has not, given, like, you should only operate on a case for hand movements or light perception, which sir has already cleared. But, I feel we have a lower threshold for vitrectomy now in cases of endophthalmitis, not endogenous, any vitrectomy. If we see suspecting endophthalmitis, we tend to lower threshold, we try to go in earlier. So, the pros of vitrectomy is we get a better diagnostic sensitivity. And there also, like the LIMS study, we have shown, they have shown that there is a reduced chance of enucleation or evisceration. The only cons is it's easier said than done, because most of these patients would be usually in ICU admitted patients, and the poor systemic status, it is very difficult to get a fitness for vitrectomy. And also, finally, even after undergoing vitrectomy, we can always, some people can always argue, what is the point, because you are not saving the vision, saving the vision of the patient. Now, a disclaimer, I'm going to stick my neck out here, okay? Don't slaughter me in the panel discussion. Povidone, this is a very interesting article I came across, and being such a platform, I definitely like to put it across. I know many people might go against me, or like probably slaughter me over here. Next, I'm expecting a very good slaughter from Dinesh right away. So povidone iodine has been used as an ocular antiseptic for long. Now, this Japanese group, what they did was they gave intravitreal injection of povidone iodine, okay, as an intravitreal injection technique, and also they used it as a irrigating solution for vitrectomy. So they had taken about 9 eyes of 8 patients, of which 3 eyes were endogenous endophthalmitis. That is the only reason I'm including it in this talk of mine. So how did they prepare the injection? What they found out was 1.25% of povidone iodine has no ocular retinal toxicity. So they have taken 1 ml, 0.1 ml of 10% povidone iodine, sterile povidone iodine. That has to be very clear, because the ones we have opened up, they are very prone to get contaminated with Pseudomonas. So they have taken 0.1 ml of povidone iodine, mixed it with 0.7 ml of saline, make it 0.8 ml, mix it well, take off 0.7 ml and inject 0.1 per ml again into the eye. And for the irrigation solution during vitrectomy, what they did is they took 1.25 ml of 10% povidone iodine, mixed it with 500 ml of BSS plus solution. So the effective concentration of the fluid is 0.025%. Now, like I told before, like even when I looked at the article, I was like, how safe could it be in the eye? And they at least documented that they have received an approval from the ethics board. So what they found out was, even after doing all this procedure, the cell density, in specular microscopy, the cell density was maintained about 2,300 per square millimeter in all the cases. And actually, it became feasible in many of the cases after the treatment. In Gorman perimetry, they found no apparent visual field defects, except in 2 cases where there was retinal whitening due to endophthalmitis. And also in ERG recording, there was no significant difference in the amplitude or the implic time in any of the components between the affected eye and the treated affected eye and the healthy fellow eyes. So key points of this study, what I found was, the half-life of intravitreal povidone iodine is 3 hours. And as an irrigating solution vitrectomy, the efficacy only lasts for 15 minutes. So it is short acting. Now, the best thing about it is the rapid bactericidal effect. It takes only 15 seconds to kill the bacteria, whereas it takes 8 hours for the vancomycin to start killing the bacteria. Also, because of its bactericidal effect, even multi-drug resistant bacteria are not a problem for it. And drug resistance is not an issue. So my take-home message, it is sight-threatening condition associated with high mortality. It requires a team approach of ophthalmologist and an infectious disease physician. Technically difficult to treat because of the delay by the time the patient reaches to us. And you know, even if you start a treatment, to get the clearance is always a hurdle to us because of the systemic issues. Early vitrectomy is always better for both diagnosis as well as treatment, and very aggressive treatment is warranted. Thank you.
Thank you, Dr. Rahul. Let's discuss about that as we go into the panel. I invite Dr. Radharamanan, Dr. Divya and Dr. Mahesh to this panel discussion. Please come and occupy the front seats. So we have Dr. Girija, Dr. Sindhu and Dr. Dinesh Talwar and Dr. Rahul. Dr. Ajay Arora is again an expert in managing endophthalmitis. So we'll straight away go into the panel. The first few minutes of our panel discussion we'll have on the OT asepsis and management, followed by endophthalmitis.
So what Dr. Thomas is going to do, he's going to present some questions and we'll have a panel discussion. If anything comes up in between, we'll have a discussion.
So first few questions are about the ventilation in the operating room and the HEPA filters. How do we ensure the safety of the ventilation and the HEPA filters? Can it go bad at any point of time? And how do we validate these?
If the filters are not functioning properly, then the contaminated air, that is the contamination occurs within the OT from the surgeon as well as the patient. If it is not filtered properly, if the filters are not functioning, then there can be contamination. But in order to prevent this only, we have two pre-filters and a HEPA filter there. It is filtering as well as purifying the air, and also the neighboring air, that is from the outside the OT as well as from other areas of the OT other than the central surgical zone, is prevented from entering the operating zone by the laminar airflow. So all these mechanisms will prevent the contamination in the operating zone.
How frequently do you have to check your filters and validate it?
Actually, a preventive maintenance is recommended every month, that is every 30 days you can check the filters, but validation is done every 6 months according to the ISO standards, and you have to check all the parameters like the air particulate count, the air circulation changes, because NABH has set certain guidelines for maintaining the OT ventilation. That is, there should be at least 20 air changes per hour with 4 fresh air changes, then a minimum positive pressure ventilation of at least 2.5 pascals. That is, in our OT it is maintained at 10 pascals, so that the neighboring air does not, contaminated air does not get into the OT. Then there should be filtration, proper filtration of the air with the pre-filters and the HEPA filter down to 99.97% efficiency, so that the air does not contain, that is the, at the grill level, it should be the class 1000. That is 1 cubic foot of air should not contain no more than 1000 particles of 5 microns or larger. So that is how it is maintained. So all these parameters, the temperature, the humidity, the air circulation, the HEPA filter validation, everything should be done every 6 months.
Thank you, Dr. Girija.
Can I ask one question here for both of you and Dr. Shashikumar? With the COVID having been here, have some things changed as far as the filtration cycle goes? Because there was a lot of talk about having another line set up in the operation theatre, which is an exhaust line. Not only the positive pressure ventilation, but setting up an exhaust line so that whatever the patient exhales, that also gets evacuated. Some of the hospitals in the country, and a lot of money was spent on making these systems. Do you think that is relevant?
As you said, there was a discussion on maintaining negative pressure in some of the areas, but I mean, I think we have overreacted in some of the COVID situations. I don't think any case has been reported because of this lack of negative pressure in the IoT. Maybe in cardiac surgery or neurosurgery it would have relevance. But I don't think there has been a reported case of complications that has occurred because of lack of negative pressure. I think positive pressure itself is good enough.
Another thing which I want to ask you, the protocols which madam you said is in a larger hospital. Many people who are sitting here who have smaller practices, do you think the protocols have to be as rigorous, or we can have protocols which are applicable whether it's a larger hospital or a practice? The protocols need to be very rigorous and applied irrespective of the practices.
The protocols have to be the same, whether it is a small hospital or a bigger hospital. I feel that it should be as rigorous as.
Dr. Radharamanan, how will you clean the instruments? How does an ultrasonic cleaner work, and how does it work, if at all?
Ultrasonic cleaner is a good idea, but whatever the thing, what is more important is your staff. See, you will have so many protocols in washing. So you yourself in random should observe it, how they clean it. And like Shashi told, it is so important to clean it immediately. Later if you use ultrasound and cleaning it, there is no need of ultrasound even if you are cleaning it immediately. So that trend, so there is sometimes when we have an ultrasound, we think that everything is solved with that ultrasound. So don't take it into that thing, and definitely you should have a NH system. So even we can have an OT without a HEPA, but what you have to make sure that your system works properly. So the surveillance, you have to monitor, you have to do everything with evidence. So you have to culture it, you have to do it everything. So that is more important.
That means, yes. Shashikumar, please.
Sir, as I said before, the earliest cleaning, it will not, the biofilm will not even accumulate. There you will have to use the enzymatic cleaning also. Otherwise, pure ultrasonic cleaning alone may not dislodge that biofilm.
So the protocol, that means you have to change the protocol if you find that you can't immediately do the cleaning. Then you have enzymatic cleaning along with ultrasonic cleaning, and then you go ahead to the sterile.
Yeah,
Is that right?
Only thing is that you will have to validate that.
No, so that's what I'm asking. What is validated? Is there a validation done of enzymatic cleaning with ultrasonic cleaning versus immediate cleaning without an ultrasonic cleaning?
I am not aware of a validation this thing for ultrasonic cleaning, but maybe you can do a culture. You can take that effluent, I mean the fluid from that cannula, and then you can do a culture and you can validate it for your OT setup.
So the take-home message is clean the instrument as soon as the surgery is over, as far as possible. If at all it's not possible, go for an enzymatic cleaning followed by an ultrasonic cleaning, and it's not as foolproof as immediate cleaning. Okay. How do we prevent wet packs after sterilization? Shashikumar.
No, wet packs occur because of lack of vacuum cycle in the autoclave. There we'll have to check it with the bovidic test or even the helix test. So frequently you'll have to check it. They say that once at the start of the cycle in every morning you should do the bovidic test. And if the bovidic test is proper, then you can assume that the vacuum cycle is good. The best thing is you have to go for even the ordinary autoclave. You can attach a vacuum pump. That costs another 60,000-80,000 rupees extra. And otherwise you'll have to go for a B-class autoclave.
How about a comparison between a horizontal sterilizers and a flash sterilizer?
No, flash sterilizer is not a replacement for a horizontal sterilizer. Flash sterilizer is only for sterilizing dropped instruments or in between cases. It cannot replace the conventional horizontal autoclave.
Sir, I had a question for you. You said these bottles, you put the needle on the top. It's
Yeah.
also important to tell people that before you put the needle on top, make sure the bottle is clean on the top. Because the bottles are transported by various means. They may not always be plastic packed. If they are coming like that and they have collected whatever dust or whatever it may be, they should be cleaned before they put needle on the top. That's very, very important.
The other option is that you will get long spinal needles. That if you put it from the bottom, the needle tip will reach above the fluid level. But the best thing is you keep the airway at the top and discard the last part of the fluid.
Spinal needle, if I think, is about 32 millimeters long. So I don't think 32 millimeters you have to get.
Those are not spinal needles. Those are needles meant for pushing air
Which
above.
we used
But
to
it's
have-
not. Yeah, we used to have it
used
for
to have
fluid air
before.
exchange.
Yeah.
But it's not. But that requires a glass needle, a glass syringe, bottle, not for the plastic
Yeah,
syringe.
those were long needles you get.
In a plastic bottle, if you make any additional hole, it's not going to self-seal. Only rubber self-seals. So what you're saying, Dr. Sai is saying, you have to do it on the top. You can't put it at the bottom. It'll keep on leaking through the edge of the needle otherwise. Your whole OT will get spoiled.
Some of the glass bottles, the plastic bottles come with the rubber stopper in the.
Yeah, so that's a separate thing.
Thank you. I think we'll have to move on to endophthalmitis. Person who had an uncomplicated cataract surgery on the first post-operative day presents like this. Dr. Mahesh, how would you go?
So I will ask the cataract surgeon how traumatic that cataract surgery was. Sometimes they might have put hook and all the pseudo exfoliation if it was a difficult cataract surgery. So I will just but any hypopyon like this, I will take it as endophthalmitis unless otherwise proved. That is the dictum. So if it is a very traumatic cataract, post-traumatic cataract or something like that, I may give a chance with intravitreal injection. Otherwise, I will treat aggressively, right?
I think you have to tell how much were the cells,
Yeah.
how much is the fundus glow.
Already hypopyon is, fundus glow is also important.
And presence of pain is an important factor,
Important factor.
as far as I am concerned. If you have pain, always err on the side of endophthalmitis.
This one looks little inflamed, actually.
Check whether this was pain or whether it's a foreign body sensation.
Yes, that is
Patients have a tendency to magnify if they are not happy with whatever they're getting, no? So even the foreign body sensation from a corneal wound, somebody may take it as severe pain. So you have to first differentiate that. Is that a foreign body sensation you're getting or is it pain in the eye per se?
Right. So if your fundus is visible and it was a traumatic case, probably I may wait for few hours. Otherwise, treat aggressively. So that is.
I presume there is no difference of opinion.
No, I think it's pain, chemosis, lid edema, hypopyon, fundus reflex.
Yes.
That's all. These are the important things. And I think when Dr. Sindhu said, one thing important, ma'am, for the TAS is limbal to limbal edema. In cases of TAS, you will have limbal to limbal edema, while in ENDOPH, there may be a more localized edema. That is again one of the differentiating.
And vitreous involvement, very
And
important.
absence of vitreous involvement in TAS versus that you covered.
Okay, this patient came after 1 month following surgery with 636 vision, no pain, and this is what we see in the fundus. Dr. Divya, how would you go about it?
This may not be a post-cataract surgery related infection. This could be some endogenous likely because, this may not be post-cataract surgery related end of infection. We need to investigate for if any other systemic like diabetes or any other immunosuppressant patient.
If the patient is diabetic, would you still take it as a post-operative, delayed post-operative endophthalmitis or an endogenous endophthalmitis?
Yeah, I mean the patient did not have any anterior segment involvement much, I think.
Yeah.
Because the view is pretty clear. So I don't expect a post-operative cataract surgery presenting a month later with an almost relatively clear anterior segment and just a posterior segment involvement like this related to a cataract surgery.
The history of any IV use in this patient after the cataract surgery or during that? This is actually a endogenous endophthalmitis and this is an ambulatory endogenous endophthalmitis. In fact, it's very important to keep in mind there are two types of endogenous endophthalmitis. One scenario is patients who present in the ICU, and these patients are very sick, and all those issues about clearances and all come in. And those patients, fungal endophthalmitis is a more common cause. The second group of patients is ambulatory patients. And we see them a lot more in this country than you see them anywhere else because of this tendency to give glucose chada do, theek ho jayega. So what happens is patients go with and the general history is a history of fever or some diarrhea, and the patient's been given an IV glucose at that time. And the patient comes 15 days later and he has an endophthalmitis. So this is likely to happen. This is an ambulatory patient likely to be an endogenous endophthalmitis due to some source which was given to him through some IV or some other form of...
Okay, we'll skip this. One patient had the first intravitreal injection for a postoperative endophthalmitis. There is absolutely no response. It's status quo. It's not improving. It's not worsening either. So what next after 24 hours or 48 hours? Would you go for a repeat injection or would you go for a vitrectomy? Dr. Mahesh?
Immediate vitrectomy. No question, because if the dramatic improvement is there with intravitreal injection and the view is better, vision has improved, fine. But no effect, there is no point in waiting. Exactly everyone told, no? Now it has become, vitrectomy has become such a we can do it.
And how often do you explant the IOL in an endophthalmitis?
Not at the initial vitrectomy. Not at the initial vitrectomy. Because it has got medical legal implications also, if I am not wrong. Suppose one patient comes with endophthalmitis, initially itself you remove the IOL, it indirectly blames the cataract surgeon and it will go for a problem. So not at the immediate thing, but the recalcitrant cases, acne, fungal, all these cases we may have to. So case by case you have to think about explantation of the IOL.
And Talwar sir, from your talk, you talked about the newer antibiotics, meropenem and tazobactam. Would you consider those as first-line drugs in any case?
The moment if you get the endophthalmitis within 48 hours,
Yes.
and specifically if it's within 24 hours. If it's within 24 hours, I won't even use my mind. I will definitely start with tazobactam along with vancomycin. It has to be gram-negative.
Exactly. We are also following the same thing. Violent, immediately, tazobactam, piperacillin. So that's...
So, Dr. Dinesh, you mentioned something which was in a talk, I don't know whether I understood it right, that if you're doing a vitrectomy and you're doing the complete vitrectomy, antibiotics are not required.
See, basically, two aspects. One is if you're doing a normal vitrectomy, a conventional vitrectomy, and that means obviously there was a PVD there and you managed to clear everything up to the equator. You've done a core vitrectomy. Actually, when the reason I would avoid an intravitreal is because now, you know, there's a controversy regarding what dose to use. Payman used to advocate decreasing the dose to 1/10. Now 1/10 I believe actually has no role, and we did a study where we actually compared this. It was actually a 4-arm study, one arm with vitrectomy, immediate vitrectomy, one with delayed, and in both, one with TAP, one with intravitreal antibiotic, one without intravitreal antibiotic. And we found that there was no difference in the outcomes when we did not give the antibiotic. So after that, I stopped adding intravitreal antibiotic even to my conventional vitrectomies. But in silicone oil related vitrectomies, anyway, I can't put in an intravitreal. You see, if I put the intravitreal and then I do a fluid exchange, fluid air exchange and put silicone oil, there is no antibiotic left. So I'm just wasting my time putting an intravitreal. And secondly, you don't need that intravitreal because with silicone oil, the systemic antibiotics now give you a very high level of antibiotic within the eye.
Before we conclude, one last question. If there is no PL or PL is doubtful in an established postoperative endophthalmitis, would you go aggressively or would you go for palliative measures? Dr. Divya.
Palliative, depends upon, like in case if you feel that there is a slightly chance for a visual improvement, and if you can do a vitrectomy through the hazy cornea with the PL vision, maybe that the corneal edema or the infiltrates might be there on the cornea, then depending upon your visualization, you can plan for vitrectomy. If some prognosis is there, definitely would go for a
No,
vitrectomy.
would you go for a radical vitrectomy with silicone oil?
If possible, if the view permits. Yeah, because it's such severe in end off, many a times you would see that the corneal involvement would be so severe that we may not permit you to go inside for a good radical vitrectomy.
So thank you very much, all speakers.
One
and
last
panelists.
comment by with Dr. Rahul's thing. I think what you said, I wanted to do because I've used it. I told my patient that he had recurrent this thing, and I said I'm going to use a Brahmastra for you, and this was a Brahmastra. It worked wonders. It does work. 0.025%. I didn't give an injection, but irrigating fluid, and the patient is happy. It's not recurred after that.
So are you advocating it as the new?
I'm not saying it's a new thing I'm advocating. I'm saying this is like if everything else is repeatedly failing.
But why shouldn't I not do it in every case then? If it's safe and it works wonders, why should I wait to first spoil the eye and then go and put it?
So I have put a food
I
I
think
have put
it's
a
time
food
for
for
the next
thought
session.
for you,
We'll have
Dr.
to leave the
Dinesh,
scene.
so that you can.
Thank you.